This is going to be a two-part talk whereby we will first talk about small bowel capsule endoscopy, and then we shall move on to device-assisted enteroscopy and potential endotherapy, which we may be able to apply as well. And my talks are mainly based on the clinical guidelines and also the technical guidelines which we've written as part of the European Society of Gastrointestinal Endoscopy working groups, as well as incorporating this much needed set of performance measures for small bowel endoscopy, again for the ESG and also for UEG. So let's talk about small bowel capsule now. As you know, it is a very different type of capsule endoscopy to what we usually do. So capsule is different from flexible endoscopy. It's more akin to radiology, whereby we are looking at still images in a sort of video format. The views are different, the resolution is different, and there's no ability to steer it. Ever since it came on the market in the first instance in 2001, there has been an explosion of different types of capsule from different companies. Some of them have two heads, some of them have a side viewing camera, and the latest one is also something that one can steer from Ancon. So it's constantly being developed. We use mostly the capsule from Medtronic, the PillCam, and this has evolved also to contain an accelerometer. So it detects movement and it increases its frame rate, and like so it reduces the risk of missing lesions. We call this variable frame rate. But it's not just about variable frame rate. The image quality has improved significantly since its birth, the capsule. And as you can see, the first images obtained by the first version in comparison to the latest version are very different and much improved. And it's also becoming even more patient-friendly. Before you used to have to attach these ECG-like leads, but now you sit there with a belt and the capsule is constantly taking pictures while the patient reads a book. I hope it's an interesting book because this takes 8 hours. And another development here is the real-time viewer, which every platform has nowadays. And this is important because before the patient leaves our department, we ensure that the capsule has actually left the stomach to make sure that we are going to get a full small bowel recording rather than just multiple images of the stomach, which can happen sometime, but this allows us to take action, like giving prokinetics, for example. The platform where we read the footage after we download it is similar for most of the different capsules. This is, again, the Medtronic one, and you can see a central image. You can even put 2 images on the screen or 4, and there's a little map here which tells you roughly where the the capsule has taken that image from the bowel. You can also play with the image, improve its contrast, and if there's a lesion there, it might become a bit more visible. So what is the role and potential issue of or issues of capsule endoscopy in the context of small bowel inflammatory bowel disease? So, and before we spin forward, I'm going to ask a question to the audience. I know that you can't answer me, but just answer yourselves in your head. So, which is the most sensitive test for small bowel mucosal lesions compatible with Crohn's disease? Is it cross-section imaging like CT or MRI, or is it small bowel capsule? And of course, capsule is a mucosal test, so it's going to be much more sensitive than anything else. It's going to pick up even the slightest areas of erythema and erosion, which are obviously not able to be seen by cross-section imaging. And studies have shown that the sensitivity is much higher, and also it's got a negative predictive value that's significantly higher. So if there's a negative capsule, chances are that there's no active Crohn's disease. But one has to remember that in Crohn's disease, there is no gold standard for its diagnosis, and it's all a corroboration of different tests incorporated with the clinical history and other findings. And even the findings at capsule endoscopy are certainly not specific for Crohn's disease. So for example, these ulcers or erosions or erythema don't tell you that this patient has Crohn's disease. If this has been done in someone who is taking non-steroidals for a long period of time or suffers from another condition, it may also be caused by those things. So an ulcer is an ulcer is an ulcer, and does not necessarily mean that the patient has Crohn's disease. So everything has to be corroborated. And just to highlight the point, so for example, this is a capsule which is showing multiple superficial aphthous ulcers, and it could be Crohn's, yes, but in this case it was this one, common variable immunodeficiency associated enteropathy. And this can also mimic Crohn's disease. Another such video, so here we are seeing a bit of edema, ulceration. You can see flicks of ulceration here, and these are relatively superficial. In this case, it was non-steroidals, and there was another case whereby there were a few deeper ulcers, and this happened to be a case of Crohn's disease. You can see the edema of the villi and occasionally a deep ulcer flying through. So here, so this was Crohn's, but again, it could have been any of these. So you need to corroborate. Going back to the guidelines and to what's quite obvious in medicine. So as you know, Crohn's disease tends to affect the distal ileum more frequently than any other place. And for that reason, an ileocolonoscopy, because the lower GI tract and the terminal ileum are more frequently involved, you can make a diagnosis in most cases. Where you have doubts and where the clinical picture is still suspicious, a small bowel capsule should be considered because it may pick up things that wouldn't have been picked up before. But we can even make it a bit more sensitive and enhance the pretest probability by looking at the clinical findings and also other investigations such as serological, fecal, and other inflammatory markers, along with the clinical picture of weight loss, constitutional upset, and extraintestinal manifestations. So don't give a capsule to everyone. Focus on those which have the highest probability. Now, another question to the audience. Again, this can be quite surprising. So what is the incidence of Crohn's disease-like lesions? So as you saw, ulceration, edema, in patients taking non-steroidals. So is it 10 to 15%? Is it 25 to 35%? Would it be 30 to 45, or would it be 55 to 75? And interestingly, up to 75% of patients taking non-steroidals for a while would definitely have lesions which may mimic Crohn's disease. So you definitely need to stop those non-steroidals about 4 weeks prior, at least 4 weeks prior to giving that patient the capsule, if you are wanting not to get your images confounded or your findings confounded by non-steroidal use. Again, the big question about retention. Retention is the dreaded complication whereby a capsule gets stuck. Not that it always needs an operation. Many times it can be managed conservatively with the use of steroids, or even time, or possibly going down with a double balloon enteroscope to retrieve it. But we wish to avoid this if at all possible. So what are the risks if you have suspected Crohn's disease? Remember that suspected is very different from known Crohn's disease. And in suspected Crohn's disease, the risk is almost background risk, like for all other indications such as angioectasias or occult small bowel bleeding, and hovers around 1.6%, whereas in known Crohn's disease, it can go up to 13%. So in known Crohn's disease, in order to avoid this thing here, which is several images showing the same stricturing area, you can see the white ring there, and the capsule just shows you that over and over again, and that is a retained capsule. And you take an X-ray and you see it there. And in order to avoid this, we use the patency capsule, which is a capsule which is the same size as the original capsule, but it is a dummy. And in essence, it's got two plugs here that allow ingress of water. And this is a methyl cellulose wrapper. And inside there is a bit of barium and a radio frequency identification tag. So with the wand that interacts with the radio identification tag, you know that there is a retained capsule in the body, and then you take the X-ray and the barium pinpoints the area where the patency capsule has been retained. So in order to avoid this retention of a proper capsule, we give the patency, and this is mandatory in patients with known Crohn's disease. Going on to known Crohn's disease, so the preferred test for assessment of disease activity or to understand what's happening at a particular point in time would be cross-section imaging, because cross-section imaging can give you an idea about stenosis. It also gives you an idea about the transmural or extramural disease, and it can highlight areas of disease activity. So this is a CT scan, a CT angiogram done in someone with active small bowel Crohn's disease, and you can see the hyperemia of the wall. So the wall is actively inflamed, and this long arrow also points to the engorged vasa recta, which in radiological terms is defined as the comb sign. And this indicates that disease not only is stricturing, but is also active. And the treatment here would be an escalation of medical therapy in the first instance. A word about reporting scores. So we've seen a lot about them recently, but there is no, one must remember that there are no validated criteria, no gold standard for Crohn's disease, and scores are there to help you standardize reporting and possibly also define disease extent and activity. And there are several of them. This is the capsule endoscopy Crohn's disease activity index, quite complex looking at it, but easy to apply. And this is the Lewis score or NIF score, which is incorporated in certain capsule software and makes it easier to apply. And this gives you an idea if you are comparing like with like, so looking at the Lewis score of a patient before treating him or her with infliximab, and then reassessing afterwards, you can actually have a longitudinal personalized care in that patient, longitudinal assessment. What about post-operative recurrence? So ileocolonoscopy remains the modality of first choice to rule out active disease at the anastomosis. Many a time this is going to be an ileocolonic anastomosis, but small bowel capsule endoscopy should also be considered if this is unhelpful. And there were a couple of studies quite a while back now, one from Bure and the other one by Pons Beltran, which showed that these capsule can be useful. In the question of IBD unclassified, so unclassified inflammatory bowel disease, and remember that this affects up to 10% of patients with colonic inflammation, its capsule use may help to reclassify, albeit the data isn't very strong. And sadly, in the context of, to assess the small bowel in the context of someone warranting a pouch and ulcerative colitis, it doesn't really help that much as we thought. So although in atypical symptoms, you may detect some ulceration prior to going for surgery, and that may actually help us to decide which type of operation to do, it's not as robust a tool as we thought it would be for this particular indication. There's been some development. So this is an evolution of the colon capsule. So this is the Crohn's capsule or Pilcam Crohn's, again by Medtronic, and it has two heads, and it is designed to assess the whole of the gastrointestinal tract rather than just the small bowel. So like so, you can assess the disease extent, even the proximal bowel. Remember that if there is jejunal involvement, many a time the course of the disease is going to be more severe, and you should have a low threshold to treat even more aggressively. So that was an input into the latest developments as well. So in summary, for part one of my talk, I hope I have shown you that small bowel capsule endoscopy may help to confirm a diagnosis. It is non-specific and findings need corroboration. It is possibly useful for the assessment of disease severity and response to treatment. And this may, again, give rise to individualized care, and escalation or de-escalation is required. And it is important to use the patency capsule in confirmed Crohn's disease to avoid the dreaded complication of capsule retention. Moving on to part two of my talk. So now it's beyond small bowel capsule endoscopy and going to device-assisted enteroscopy or DAE, plus endotherapy, because DAE, as you know, device-assisted enteroscopy allows us not only to take biopsies, but also to treat things. And I will focus a bit on stricturing disease because that is where the importance of this lies, I think. So I've split this into learning objectives. It is to understand the nature of the problem, to understand which inflammatory bowel disease related strictures are amenable to safe and effective endotherapy, and also to understand the outcomes of such therapy should it be applied. So even in 2020, it's still a major disease burden. So the stricturing formed by Crohn's disease, even though we've got drugs that can reduce inflammation quite significantly, we still run after the holy grail of antifibrotic drugs, so drugs that can limit fibrosis. And once that sets in, it's a problem because anti-inflammatories don't really work. And sadly, stricture increases with time. Stricture risk increases with time. And it remains a significant problem despite recent advances, and this responds poorly. And what is intestinal fibrosis? It's a conglomeration of several things that contribute. It involves the immune system and also disease characteristics, genetics, and the environment, and their interplay. So once this sets in, sadly, it's difficult to treat. So the stricture risk in Crohn's increases if the ileum is involved, and it goes down according to where other parts of the gut are involved. And it can present with cramping pain, usually subacute obstruction or bloating, some weight loss, and then subsequently patients may present with florid small bowel intestinal obstruction, with this case showing exactly that, with two strictures showing a bowel which is full of fluid in an obstructed patient. So for evaluation, one must always corroborate again, so the clinical history and examination. One must also look at hematological and biochemical markers to understand whether this is ongoing inflammation or whether this is mostly fibrosed, and dedicated cross-section imaging can actually also help. And in this case, as I showed you before, there is active inflammation, so this is going to be for medical care. Going back to capsule, capsule in this context is a good scout. It is a minimally invasive thing like a drone, but when we need things that dive deeper, apart from knowing that it can get retained in the context of stenosis, limiting its use in this area, we would need to know what is causing the potential inflammation, because as I told you before, not all that inflames is Crohn's and not all that strictures is Crohn's. So for example, here you can see this area again in cross-section imaging mimicking Crohn's disease. There's also the comb sign, and on radiology, unless you corroborate all the findings, you should think, or you would think, that this is likely to be Crohn's. But beware the great mimicker, and in this case the great mimicker was tuberculosis. So this is TB of the small bowel mimicking Crohn's disease, and you can see the gone focus on the x-ray there. Another mimicker, sadly malignancy, melanoma, loves to go to the small bowel, and this is a case where again Crohn's disease was being mimicked by melanoma metastases. So enter device-assisted enteroscopy, whereby it allows us to take samples, but also allows us to apply therapy. So not just diagnostics, but also therapeutics. And this is important because although this case looked like lots of inflammation, we needed to take biopsies because the only area that was involved was the jejunum, and on the CT scan there was doubt as to whether this was a lymphoma or possibly Crohn's. And device-assisted enteroscopy allowed us to take biopsies. It also allowed us to make a diagnosis. The patient was given anti-TNF therapy and did very well. Another case where biopsies helped, this again could be Crohn's disease, or it could be non-steroidals, or it could be something else. It occurred in a patient who had suffered from multiple upper respiratory and lower respiratory tract infections throughout life. And then when we biopsied, there were no plasma cells on biopsies, and this proved to be a diagnosis of common variable immunodeficiency associated enteropathy. Interesting, another similar case there. And even in this case, again, ulceration and bleeding, you think that this could be inflammatory bowel disease. Why not? This was the sad case of a patient who now passed away in the context of sepsis from immunosuppression in the context of renal transplantation. And this happened to be the findings we found in the context of norovirus infection. So again, not everything that ulcerates or strictures is Crohn's is a non-steroidal stricture, again mimicking, and this is multiple strictures like rings induced by selenium over supplementation. And again, stricturing can be caused by other things such as a macular diverticulum, which had caused ulceration and stricturing. So not all that strictures is Crohn's. A bit more about DAE. So device-assisted enteroscopy, first developed by Professor Yamamoto and came onto market in 2001. So many years have passed. And the reason why we needed something of the sort is that the bowel is a long and floppy tube. And if you try to push an instrument into it, all you do is loop and curl away and stretch the bowel. And with his genius, Professor Yamamoto came up with the idea of anchoring the bowel, and he came up with double balloon enteroscopy. So by inflating this balloon, you provide an anchor, gently gripping the small bowel, and then with the overtube going down, you inflate the overtube balloon and mimic that anchor, and then deflate the scope balloon, go forward, and then with both balloons inflated, you pull back. And like that, you not only go very deep, almost pan enteroscopy, but you also shorten the bowel, enabling a 2-meter scope to scope a much deeper length. And you can go down from the top end or up from the bottom end. And it is a very useful and very, very safe and gentle tool. Single balloon came a bit later, same principles, but missing one balloon. And then spiral enteroscopy was developed by Paul Ackerman in 2008. And as you know, it is now being brought into clinical practice in its motorized form, albeit in this context, especially in patients with Crohn's, we need to understand whether this is going to be suitable or a suitable tool, especially in terms of safety. Balloon guided is another one that came on. This is interesting in that it uses a catheter, which has a balloon at its end, and if you incorporate it with the GI scope from Pentax, you have a sort of pseudo double balloon system, albeit it doesn't go as deep as the proper tool, but it's useful to apply, I think, if you don't have specialist enteroscopy kit and you just need to get a bit deeper. So this is our preferred tool, double balloon enteroscopy, and that's us doing it at roll free. I'm here down in the colon from the mouth, about 6 meters down. And in the right hands, it can be done in quite a rapid amount of time. We only took about an hour to get into the ascending colon from the mouth. So it is a useful tool. But it's not just about treatment. Device-assisted enteroscopy, as I told you before, allows you to confirm or refute a diagnosis by biopsies. So this is the picture I showed you earlier on in the case where we were doubting lymphoma and turned out to be Crohn's. And this is the small bowel of a young patient, a child, and we were in Shore, so went down. I was asked by my pediatric colleagues to go down and assess. And even though this ulcerated area is healed, this enough is useful to tell you whether this is Crohn's or something else, because if you get ulceration or healing along the mesenteric side, it is much more likely to be Crohn's than other causes of inflammation. But going back to the interesting bit, I think the more interesting bit, endoscopic balloon dilatation, how do we do it? So you have to select your cases very carefully. And when we do it, so it has to be a symptomatic patient, because if your patient is asymptomatic, regardless of the presence of strictures on imaging, don't dilate. So symptomatic, ideally the stricture is fibrotic, so there's a minimally inflammatory component, because the risk of having complications with active inflammation is higher. The stricture has to be short, so 4 centimeters or under, because otherwise the overall success rate is lower. It has to be straight and not angulated, because an angulated stricture increases the risk of perforation on the contralateral wall. Not associated with fistulae, because complications ensue, and there have to be few strictures. And this is an example of a stricture we would dilate, so short and minimally inflamed. And this is a stricture we would not dilate, long and quite inflamed. Another example of a short stricture, and this is the one on the left, is the type of stricture we would dilate, and the one on the right with active inflammation, for sure not. So prior to proceeding with endoscopic balloon dilatation, ensure that we've optimized medical therapy. We also have to get a good understanding of the stricture anatomy and number. So cross-section imaging is extremely helpful, and know the characteristics, lengths, and numbers. How do we do it? We use a through the scope balloon dilator, endoscopic balloon dilator. My preferred one is that by Boston Scientific, the CRE balloon, because it allows you to look directly into it by adjusting the tip of the scope looking into the balloon. But if you flood the area with saline or water, it can be done with any other balloon as well, because as long as you have a clear view through the balloon, you are able to do this a bit more safely. Although it's not absolutely mandatory, ideally we should do it under fluoroscopic guidance, depending on availability and the type of stricture dilating, but we would recommend this. And have good views and a stable position. If you don't have good views, if you don't have a good stable position, abandon it, don't dilate. And do it gradually, following the rules of trees, and do not really exceed 22 millimeters in diameter in the small bowel, because you run the risk of a perforation. So this is the fluoroscopic view, and what we would see through the scope balloon, endoscopic balloon dilator. You can see this white ring of tissue that is being stretched and dilated, and this is the equivalent view on a fluoroscopy. And this is my dear friend and colleague Alberto in my unit doing it under fluoroscopic guidance. And this is a short video of such a short stricture. I took some biopsies to confirm as requested by the referrer, and I flooded the area with saline just to get a better view through the balloon, and that is the classical ring, white ring you get, and that's a second stricture in the same case being dilated. These were short strictures, ideal for this type of therapy. And again, holding the balloon, we usually hold it up to about a minute or two, deflate and inspect the site and make sure that all is well and that there wasn't any problem, and the scope passed through nicely. Our colleagues who have a very strong relationship with us from Jichi Medical University in Japan, Professor Yamamoto and Professor Tomo Noriano, came up with this distal attachment, which is designed for dilatation of strictures in the context of small bowel Crohn's disease. And this is called the cast hood, which is an abbreviation for calibrated small caliber tip transparent hood. And essentially, this is like the ST hood used for ASD, again, developed by Yamamoto et al., but it's got markings here so that it allows you to understand how much, how wide your stricture is and what balloon you would use. And its tapering edge also allows you to go through many strictures, allowing you to dilate several in one session. So post-procedure, one must observe for a couple of hours, one should be vigilant for pain, and one should be careful to give just clear fluids for a few hours and have a low threshold to scan should any symptoms arise. Aftercare, so don't forget that you need to optimize medical therapy. You also need to continue asking your patients to stay on a low fiber diet, because although you've dilated, you've not eliminated stricturing disease. And test and treat for bacterial overgrowth, very important. And of course, reevaluate regularly. And the beauty about this is that you can repeat treatment as is necessary. And in this context, we look at the outcomes, all right, because without outcomes, we are not able to get any evidence. And this is a colleague of ours from Japan, Dr. Hirai, who did a meta-analysis and review collecting 8 studies with a pooled number of patients of 245, and this showed very good efficacy up to 87%, with low perforation rates which hover around the 4.5%, which is acceptable. And these are the data, the studies here. One of them was ours a while back, showing the efficacy and also the perforation rate. And the long-term data, he did a study then about long-term data because the previous studies showed medium to short-term data, and N was 65, so 65 patients. And this is interesting and encouraging. 79% of his patients were surgery-free at 2 years of follow-up, and 73% were surgery-free at 3 years. So if you can keep on avoiding operations in the context of carefully selected strictures, you are doing your patients great favors. And this is taken from our old paper, which shows that the symptom scores decrease very significantly after dilatation. What are the main predictors of dilatation failure? Well, if your stricture is over 4 centimeters, it's unlikely to have a lasting effect. And smoking may increase the need for redilatation or for treatment failure. What about concomitant therapy, so injecting steroids into the dilated stricture, or infliximab injection therapy? Well, the data is inconclusive. And what about stents? Again, biodegradable stents, although they seem like a good idea, they can create a huge inflammatory reaction, and their overall benefit is inconclusive, and they have a potential risk of longer-term complications. So in summary, I hope I have shown you that DAE for endoscopic balloon dilatation has good outcomes in carefully selected cases, may reduce the need for surgery. It may be repeated, so that's an attractive option, and it is relatively safe with the risk of perforation hovering around 4.5%. I would like to thank our team, which continues to expand. So the newcomers here are Dr. Alexandros Kamelos and Dr. Rocio Chaki, who have joined us recently and are training in advanced endoscopy and doing some research. And I also wish to thank our GC colleagues because of our strong relationship. They spend a long time with us, coming for months on end to do all free. Although nowadays we're more likely to look like this. This is us in our new day-to-day world. And if you are running short of PPE, we've come up with an idea of constructing a disposable single-use face shield with cheap materials. So this is useful given the shortage of PPE worldwide. And of course, although we don't know what's going to happen and whether this would be held in person, we certainly would do something for our International Advanced Endoscopy Masterclass, which has become so popular. So I think we should save those dates because we will definitely offer you something. Thank you so much.
Hello, Professor.
Hello, can you hear me?
Yes, you can go directly to the questions now. You have around 8 questions.
I'm seeing them. So thank you for your interesting webinar teaching. Please, may I ask you whether you would recommend patients to be referred for DBE and biopsy if small bowel endoscopy showed Crohn's disease-like stricture with aspirin or non-steroidals, nor other offending drugs prior to starting immunosuppressive therapy? Well, this is a very good question, and I thank you for it. In essence, I think you should corroborate everything. So apart from the clinical picture, you should look at your blood investigations and also radiology. And if the history and the radiology fit in, you don't necessarily need biopsies. But given the fact that you are aiming to start immunosuppressive therapy, if there is a doubt, then of course it needs to be, you need to rule out important things. So I would definitely consider taking some biopsies, but it always depends on the corroborative clinical picture. Okay, now let me go to the next one. So one more question. May I ask what would be your opinion regarding training and certification? So training and certification in reading capsule endoscopy in the UK or other European number of supervisors. So at the moment we're writing the curricula both for the ESG and also for the BSG colleagues, including ourselves, and of course being led by others such as Rina Sidhu in Sheffield are writing these curricula, and they should come up shortly. So it's not just about numbers, but it's also about the quality. Hello, what is your management of the patient when the capsule gets stuck? Haha. So in essence, what I would do here is, it depends again. If the patient is really at extremis and in pain, the stricture has caused the capsule to impact, then you need to work emergently. And in the first instance, I would prefer to go down with a double balloon scope before considering an operation, albeit sometimes surgery is necessary if the bowel is completely obstructed. But this situation can also be managed conservatively. And if there's a degree of inflammation on cross-section imaging, you may want to give anti-inflammatories such as steroids to help the capsule pass. Okay, do you know about the development of capsules with possibilities of sample taking? So yes, this has been a sort of holy grail type of thing for a long time. And although the idea, albeit probably no longer science fiction, is cool and, it appeals, I don't think there's anything available or almost available as yet, but I suspect something would become available over the next 10 years or so, albeit I can't be certain. Okay, so can Crohn's disease medication on terminal ileal findings of aphthous ulceration or biopsy is mandatory after exclusion of mimics? Okay, so I suspect what your question relates to is, can we start medical therapy if we've excluded mimics, or do we need biopsy? So many a time you will find terminal ileal ulceration at colonoscopy. And it is very easy to take some biopsies. The problem is that many a time the biopsies are only exclusive. So they exclude things like TB or infections, but they don't give you a diagnosis. Again, there is no gold standard diagnosis for Crohn's disease, and the biopsies will just say non-specific inflammation. So if the whole corroborative picture fits, you can actually start treatment. If it is not that severe, I would start with something like budesonide in the first instance, okay? Is there any role of NBI during enteroscopy? Dr. Moshin from Bangladesh. Thank you, Dr. Moshin from Bangladesh. Nice of you to join us. So in essence, NBI is a proprietary term for narrowband imaging, which is made by Olympus. And although they incorporate it into their single balloon scope and possibly also the spiral scope of late, Fujifilm uses a different type of technology, and they've got their own things. But to answer your question more generally, does contrast imaging help? This is, I think, what you're trying to ask me. It may or may not. I don't use it in my day-to-day clinical practice, I must say. There's very rarely things that need dyes or contrast in the small bowel, because polyps are usually obviously going to be inflammatory or hamartomatous, like in PJS. And if there's an adenoma, you can tell usually without the need for contrast. So it's not like the colon here. So the need for that is rather limited. There's another question. Do you think stricture dilatation up to 22 millimeters is safe as Crohn's disease is fibrostenotic disease? Again, Dr. Moshin from Bangladesh, thank you. We have dilated up to 22 in our series. I think you have to be cautious, so around the 20 mark is okay. But as long as it's short and fibrostenotic and you do it gradually, you can hover up to the 20-22 mark, but you have to do it very cautiously, okay? And you know what you're doing. Okay, I mean if biopsy normal or non-conclusive. So biopsies, I suspect is the same question here that we've answered before. So you meant biopsy normal or non-conclusive. So I think that most biopsies are going to be non-specific. And if you have a corroborative picture in keeping with Crohn's disease, then I think you should still treat once you've ruled out other things, of course. Hi, Dr. Despott. For your dilatation, do you use the spiral enteroscope or double balloon enteroscope? So we use double balloon enteroscopy. It is our staple enteroscope. I think there is still a lot of work and study to be done with the latest spiral enteroscope. So double balloon has been tried and tested and shown to be safe in most scenarios. So I think for the time being, we shall stick to double balloon. And what is the preparation before video capsule? Use prokinetic. Thank you. Thank you for your question. So I think that the use of bowel preparation, although there was a recent meta-analysis from Greece that came up with some confounding, data of a meta-analysis, I still think that the world favors a preparation because it improves the views. So by preparation, I mean polyethylene glycol. Do we use a prokinetic? It depends. I mean, I use a prokinetic only if the capsule has stayed in the stomach for a while. Okay, so I think we're getting to the last question. So I think there's a question that says, if the first dilatation was not successful, can we repeat the dilatation? And the answer is yes. Of course, you are saying that not successful, I take it, being clinical symptoms have persisted. If that is the case, you can repeat. But of course, if it wasn't successful because of technical issues such as angulation and inflammation, then of course you can't repeat it. But many a time you can repeat. Well, I thank you. It's been an absolute honor and a pleasure. I'm sorry I couldn't answer all your questions. We're out of time. There have been many questions coming in, but thank you so much.
Thank you very much, Professor Despott. Thank you, everyone, for joining us today. Thank you.
Thank you. Take care.
Bye-bye.
Bye-bye.